Dear colleagues, greetings from all of you everywhere in the world. It is my pleasure to invite you to this webinar series on IgA nephropathy and focal segmental glomerulosclerosis. This is the episode number 2. It will deal with management and treatment of IgA nephropathy and recommendation for future research in this disease. During this webinar, we will review the initial management of IgA nephropathy, and we will consider the treatment of patients with IgA nephropathy at high risk of progression, examine the role of glucocorticosteroids as well as new therapeutic options. I will be the moderator, and the panelist will be Richard Lafayette, professor of Stanford University Medical Center in the States. Let me briefly introduce myself. I was the head of nephrology, dialysis and transplantation unit at the Regina Margherita Children's Hospital in Turin, Italy, and chaired the course of pediatric nephrology at the University of Turin. I am presently a member of the ISN Council and the chair of the Western Europe Regional ISN Board. I'm the co-chair of the scientific program of the IPNA Congress in Calgary in September. I've always been involved in glomerular diseases, in particular in IgA nephropathy. And this is indeed a unique glomerular disease because it is very well identified by the prevalence of IgA as a dominant class in glomeruli. However, this disease has a variable clinical feature and variable renal lesions, as masterfully reported by Professor Agnes Fogo and Professor Jürgen Flöge in the first episode of this webinar series. And these variable clinical features and variable renal lesions accounts for different outcomes, from a symptomatic form with minimal urinary abnormalities to remission after an acute phase, or an indolent course, or a progression which can be slow or even rapid. But in most cases, IgA nephropathy is a variably progressive renal disease. The point is that the rapidity of progression of individual patients is different. So we need an individual prognostication on the rate of loss of GFR in order to select patients to be treated. We know that follow-up proteinuria is a relevant risk factor for progression of IgA nephropathy, and the threshold of 1 gram of proteinuria per day persisting over time, the so-called follow-up proteinuria, was considered by the KDIGO 10 years ago. However, we need a long observation time and repeated measurement over years to assess this risk factor in individual patients. So we need to know at the moment of kidney biopsy which is the risk of progression for individual patients. And to answer this question, the International IgA Nephropathy Network assessed this risk prediction tool of IgA nephropathy, which can predict the time of renal biopsy, the risk of 50% decline in kidney function or end-stage kidney disease. This is based on the integration of clinical and pathology data, and the calculator is available on the web. More recently, this month, indeed in July, the same group has published the update of this prediction tool for patients needing the prediction of risk 1 or 2 years after renal biopsy. So it is likely that the idea of selecting patients at risk of progression only on the basis of proteinuria 1 gram per day and established treatment in these patients may be not completely true. For instance, applying this international IgA nephropathy prediction pool, 47% of patients with proteinuria higher than 1 gram per day would not qualify for treatment. And on the other hand, 70% of patients with proteinuria lower than 1 gram per day would qualify for treatment using the treatment decision model based on international IgA nephropathy tool. And moreover, also the progression. We are familiar with the progression, the linear decline of GFR as we see in adult patients, but the same group reported a different trajectory, for instance, in pediatric cases, with an initial increase in GFR after the detection of the disease after the acute phase, then stabilization in the plateau, and a falling decline, which is linear after 3-4 years. And of interest, the cases with a lower increase after the acute onset are those more exposed to progression. So there is a need in individual cases of identification of patients which can have a late progression. This is the case for children, because in children we know that the disease is likely to be benign, particularly at the beginning. But if we look at long-term follow-up, the case is not like that. In some cases can progress to end-stage kidney disease. So the dilemma in IgA nephropathy is the risk of overtreatment with unnecessary drug exposure in patients with acute and often self-limiting inflammatory disease. Or on the other hand, a risk of undertreatment of vasoactivity leading to late progression. And furthermore, we may wonder if corticosteroid and conventional immunosuppressors are the only treatment options for patients with IgA nephropathy at risk of progression. Indeed, there is a large series of new drugs under evaluation for treatment of IgA nephropathy, and Dr. Lafayette will present, will discuss. So it is really an extraordinary moment for IgA nephropathy because there is a big offer of new drugs which can allow, we hope, or will allow to choose the right therapy for the right patients and to go for personalized treatment. Our discussant will present this data, will clarify this difficult issue. He's the right person for this issue. Professor Lafayette is professor of medicine at the Stanford University Medical Centers. He's the founder and director of Standard Glomerular Disease Center and the fellowship program. He earned his medical degree in New York Medical College, internal medicine at Long Island Jewish Medical School, nephrology at the Stanford University. So, Richard, please, we are waiting for your lecture. At the end of the lecture, we will have time for questions and answers. So please, during the lecture, type your question so we will have time to discuss it. Thank you. Please, Richard.
Thank you very much, Professor Coppo, for your very kind introduction, and it's my great pleasure and honor to be here to talk about IgA nephropathy and an approach to treatment. As we get started, I think it's very important to realize that the field of IgA nephropathy is undergoing dramatic changes, which I think is for the benefit of our patients, and that understanding who and how to treat our patients is really, really more critical than ever before. And to start with our treatment, we have to understand who's at risk for progression and who needs various therapies. And therefore, when we look at the risk for progression, I believe it's really important to apply the International IgA Nephropathy Network's risk scores. And in doing so, you can find populations who are at relatively low risk, those that have biopsies with relatively mild findings in terms of Oxford scores, those with intact kidney function by their estimated GFR, those with normal blood pressure, and with urine protein excretion of less than 500 milligrams per day. Now, long-term, these patients may come to risk and need more aggressive therapy, but with supportive care, these patients generally do well. At more moderate and higher risk are patients with more active, more chronic biopsy changes with urine protein excretion rates of more than 1 gram per day, those with reduced GFR or kidney function, and those with other risk factors such as uncontrolled hypertension, and they need our attention, they need our therapy for sure. Of course, I think we all get a little bit more anxious with even higher risk patients, those with greater levels of proteinuria, perhaps more than 3 grams per day, those whose GFR are falling under our care, and those with even more aggressive biopsy findings of more advanced fibrosis, of crescents, of more significant inflammation. And then finally, there's those patients who need other considerations, those with rapidly progressive glomerulonephritis we will not be discussing today, with more than 50% crescents and relatively rapidly rising creatinine. So you've got to, again, think about your patients, what their risk for progression is as you start considering treatment for IgA nephropathy. And this is simplified somewhat in the KDIGO approach to the treatment of IgA nephropathy. Again, they start out by removing certain patients from consideration, those, as we mentioned, with rapidly progressive glomerulonephritis, those who have more of a minimal change presentation, and those patients with secondary IgA nephropathy associated with cirrhosis, with other systemic inflammatory diseases. And then they really look at risk mainly as those patients who have persistent proteinuria of more than 1 gram per day, despite at least 3 months of optimized supportive care with maximally tolerated doses of ACE inhibitors or angiotensin II receptor blockers with the best blood pressure management and with undergoing lifestyle modification and reduction of cardiovascular risk. And for those patients that are still at significant risk with substantial proteinuria, the main suggestion as of the guidelines being published last year was to consider enrollment in a clinical trial. And if that's not possible, if they have low kidney function, less than 30 mils per minute, then maybe consider maximal supportive care. However, if those patients are more inflammatory than more fibrotic, maybe they fall into other considerations, but the KDIGO approach would be consider really maximizing supportive care. And if they still have GFR greater than 30 mils per minute, then you may want to consider corticosteroids, and you have to really fully think about the risk-benefit profile of glucocorticoids and individualize your therapy is what's suggested by the KDIGO approach. Now, they do point out, as you can see in the right, that specific populations may have other considerations, that specifically in Japanese, there may be some role in tonsillectomy based on less than perfect data, that in a Chinese population, mycophenolate still should be something that could be considered. So again, individualizing your therapy is the golden rule, but at this point, you've considered high-risk patients, you've maximized their conservative therapy. For those who still have GFR, that's worth fighting for. The idea was to consider glucocorticoids. And again, what KDIGO suggests is that those patients who you're thinking about corticosteroids, you need to be cautious because there are concern for side effects. And there's relative contraindications for corticosteroids, and they outline them as patients, again, who have increasingly low GFRs, those with diabetes, those who are overweight, those with latent TB, those with secondary diseases where there may not be studies assessing corticosteroid therapy, those prone to peptic ulcer disease, those with uncontrolled psychiatric illness, or those with severe osteoporosis. So again, risk assessing your individual patients before further considering the risk benefits of corticosteroids. And again, initially we'll deal with how did we get here in so much thought about corticosteroids for IgA nephropathy and thinking about risk benefit. Well, already more than 10 years ago, and in fact, over the past several decades, there's been this ongoing conflict of successive studies showing benefit of IgA nephropathy treatment with corticosteroids versus no benefit. And this is in part outlined in this review slide by the testing group published in JASN about 10 years ago, looking at multiple studies that underwent meta-analysis, ultimately showing a trend towards a benefit towards hard outcomes for patients with IgA nephropathy with corticosteroid treatment, but based on several underpowered studies, which, as you can see, go back and forth between showing benefit and no benefit. So there was a clear need for further understanding of the role of corticosteroids in IgA nephropathy. And in part, we started to get that again about a decade ago when the Valiga study that was validating the Oxford score looked back and said, well, how did patients do with immunosuppressive therapy that we looked at them? And they did a propensity scored analysis of initially about 360 patients who had either undergone immunosuppression or not, while all being treated with conservative therapy. And in that analysis, as you likely know, they demonstrated a substantial benefit of immunosuppressive therapy in terms of patients with IgA nephropathy surviving from a combined event of doubling their creatinine or going on to need dialysis or transplantation. And this was most obvious in those patients at the greatest risk of progression, those with less than 50 mils per minute, and a little bit less marked in those patients with more preserved kidney function. But it started moving the field more towards one that sort of embraced treatment with immunosuppression for patients who are still at risk for progression of IgA nephropathy. However, soon after that, we saw the results of the STOP IgA nephropathy trial, a well-powered, randomized controlled study of patients with significant proteinuria, more than 750 milligrams per day, with preserved kidney function, who after 6 months of optimized kidney function still had substantial proteinuria, and then were subjected to immunosuppressive therapy with either corticosteroids or combined immunosuppression for at least 6 months therapy. And as was shown, there was a significant outcome where more patients achieved full control of their proteinuria or full clinical remission in the upper panel. So there was substantial response to an antiproteinuric effect, but in the initial analysis, there was no improvement in kidney outcomes. So no difference in eGFR decreases greater than 15 mils per minute. So the authors suggested perhaps corticosteroids had already been oversold and aren't a good therapy for our patients, because they also found, as you can see here, that those patients who underwent immunosuppression had far in excess infection, approaching a p-value of less than 0.05. They had impaired glucose tolerance or diabetes mellitus as a consequence of corticosteroids, and they gained weight. So not only was there no clear benefit to kidney function in the short term, but there was substantial side effects seen in the STOP IgA trial, including an infectious death. And when the authors looked at their population even further out with a mean follow-up of beyond 5 years, as you can see here, there was really no difference in these long-term events of doubling creatinine or coming to dialysis in the patients who received immunosuppression plus supportive care compared to those only receiving supportive care. So this sort of dampened enthusiasm for glucocorticoids in patients with IgA nephropathy. And at the same time, again, lots happening in the last few years, the testing trial released their data, and they had screened over 500 patients and had randomized their initial 262 patients on their way to wanting to evaluate 1,000 patients randomized to corticosteroids versus non-corticosteroid therapy, supportive care with maximally tolerated ACE inhibitors, angiotensin II receptor blockers. And they were able to evaluate 134 patients who received methylprednisolone at a solid dose compared to those who were treated with supportive care. And as you likely know, this study was actually stopped by the Safety Monitoring Committee due to the panel on the left that there were too many serious adverse events. Those were happening within the first few months of therapy, and these were severe infections, including infection-related death, so the study was stopped. However, by the time the study was stopped, there was already data on the right hand suggesting that there was an impact on the composite endpoint in this population, where the combination of 40% reduction in GFR or end-stage kidney disease or death from kidney failure appeared to be substantially reduced by corticosteroid therapy. So again, the Data Monitoring Committee stopped the study due to the imbalance of severe adverse events, and the steering committee chose to discontinue that treatment wisely, but to continue the follow-up of those participants, and then to modify the protocol, what we call the testing low-dose study, utilizing now an initial dose of 0.4 milligrams per kilogram of methylprednisolone, adding pneumocystis prophylaxis for the first 12 weeks, and including patients with GFRs slightly higher in the 30 mils to 120 mils per minute category. And this data that was published recently in JAMA again showed that this approach overall led to reduced events of 40% reduction in GFR or the need for dialysis or death due to kidney disease. So there was a substantial reduction at these combined doses of methylprednisolone. As you can see in figure B, again, just looking at kidney failure, that was also significantly reduced, that the cumulative incidence had been reported earlier, but now in an extended follow-up, there was a maintenance of the reduced endpoint in the full dose cohort, and that the reduced cohort in the bottom right panel, panel D, was also successful at reducing this outcome. Again, there was shorter follow-up at the time of this publication, but there was significant reduction in events. So again, in this population of mostly Asian patients with GFRs above 30 mils per minute and ongoing proteinuria, corticosteroid therapy looked like it could reduce events. But again, this benefit was seen broadly, both in the full dose and reduced dose groups, both in high dose and low dose subjects who had higher or lower proteinuria, higher or lower kidney function, different findings on their initial biopsy. In fact, even though the study was predominantly done in the Chinese population, the non-Chinese patients also had a benefit, younger or older. So it looked like pretty substantial homogeneous effects of corticosteroid therapy to reduce events, but there was still this very strong imbalance in overall adverse events. And this table shows the serious adverse events. And again, there's 5-fold greater serious adverse events with corticosteroids than placebo. And on the right, you can see that that was mostly seen in the higher dose group. But those serious adverse events fell from 30 to 7 in the lower dose group on the right-hand side, but it was still higher than that experienced by those with conservative therapy. And again, the data shows that the urine protein was impacted by corticosteroid therapies at both doses. That reduction of proteinuria was maintained for up to 2 years before there was loss of the antiproteinuric therapy, that the main benefit was seen that there was an improvement in eGFR and kidney function early after corticosteroid therapy, and then the groups sort of carry on mostly parallel after that, so that an initial preservation of GFR led to long-term benefits. And again, the idea that was initially, while there was about a wash between the regular dose corticosteroid therapies benefit and harm, the suggestion is you may see more benefit than harm with the lower dose therapy. But there still may be benefit, but there's still harm as well. And so the idea would be that there's still opportunities to do better with our therapy for our patients, and we need to learn more. And fortunately, we are learning more about the pathogenesis of IgA nephropathy. Here's just one cartoon that's been well circulated and well published that suggests again that IgA nephropathy is a disease starting with mucosal activation in genetically predisposed patients. You get a stress at your mucosal system, likely an infection, that leads to B cell activation, production of more IgA at that site, which will be predominantly galactose deficient IgA. And with that coming into the systemic circulation, you have the opportunity to build autoantibodies to that IgA and form immune complex. That immune complex can both specifically and non-specifically bind to the glomerular mesangium, in which case you can develop inflammation, leading eventually to scar and damage and reduced kidney function. And over this last decade, we've seen that each of these steps and each sites may have the ability to specifically target them and thus reduce the risk of progressing in your IgA nephropathy by reducing either the inflammation, the immune activation, or the ultimate fibrosis of the kidney. And therefore, we've been lucky to see a huge number of emerging therapies in IgA nephropathy, both in the non-immunosuppressive realm, or perhaps non-immunosuppressive realm, and more stabilizing conservative care realm, and in the immune modulating therapy realm. And I've listed several of these, including endothelin blockade and dual endothelin and angiotensin receptor blockading approaches, SGLT2 inhibitors, perhaps aldosterone blockade, immune modulating therapies such as targeting corticosteroids, using hydroxychloroquine, blocking the complement pathway, blocking B cells, using other ways to activate corticosteroids such as ACTH, are all things undergoing evaluation. Again, where we have stronger data includes SGLT2 inhibitors, again, with the idea that diabetes mellitus and the use of SGLT2 inhibition has been shown to have impacts on kidney function that may be beneficial. And therefore, SGLT2 inhibitors, by blocking the uptake and reabsorption of glucose, can lead to glucose and sodium wasting, can activate the juxtaglomerular apparatus along with other mechanisms, reducing intraglomerular pressure and perhaps preserving kidney function when there's proteinuric kidney disease. As you know, the DAPA CKD study showed broad protection, again, reproducing findings from multiple other diabetic kidney studies, but in a large non-diabetic CKD population, showed broad benefits in terms of stopping progression of kidney disease, and in a subset of patients reaching 270 patients who again were just slightly older and slightly more advanced disease than is typically studied in IgA nephropathy, but with a GFR, as you can see here, of about 44 mils per minute, and proteinuria likely exceeding 1 gram per day because the albumin to creatinine ratio was just under 1 gram per day. In this population, they were able to demonstrate a very substantial impact on the primary kidney endpoints in terms of a marked risk reduction of these endpoints in a population of IgA nephropathy utilizing an SGLT2 inhibitor. And as you can see, this was true for the primary endpoint, for the renal endpoint, as well as the primary endpoint in the vast majority of the patients who had IgA nephropathy proven by biopsy. So again, good preliminary evidence that SGLT2 inhibitors may be beneficial in IgA nephropathy and may be coming to standard care for patients with IgA nephropathy who don't meet your treatment goals after standard therapy. Again, another emerging therapy may be endothelin receptor antagonists, because again, multiple studies have demonstrated a central role for endothelin A receptor agonism to lead to multiple complications in the kidney, including vascular injury, podocyte damage, renal tubular interstitial fibrosis, mesangial proliferation, and glomerular sclerosis, and the recruitment of inflammatory cells into the kidney. So blocking endothelin has long been a goal of treating kidney disease and of treating IgA nephropathy. And as you likely know, in diabetic nephropathy, atrasentan demonstrated a large potential for benefit in IgA nephropathy in a very large study, more than 2,600 patients, who were then enriched to see if they can tolerate endothelin blockade without fluid overload and with the ability to tolerate the blood pressure and see some impact on urine protein. And long-term follow-up showed a reduction in outcomes in diabetic nephropathy. And atrasentan is currently undergoing a phase 3 trial evaluation in IgA nephropathy. Furthermore, dual endothelin and angiotensin II receptor blockade is possible in medications, and there's already been phase 2 data with sparsentan demonstrating, as you can see in this figure, in focal segmental glomerular sclerosis, that treatment with sparsentan versus an angiotensin II receptor blocker led to greater reductions in proteinuria and greater achievement of what was called fractional partial remission, a condition which has been associated with reduction in hard outcomes in focal segmental glomerular sclerosis. Similar preliminary data was shown in IgA nephropathy as well. And as you know, there's currently a phase 3 trial going on with sparsentan in the PROTECT trial, and complete data should be available sometime next year. But the preliminary data demonstrating a substantial reduction in proteinuria, at least in the United States, is undergoing evaluation by the FDA for early approval. So when we go beyond these conservative therapies, where we do have upcoming enrichment to our armamentarium, we have to think about, are we going to still utilize immunosuppressive therapy, or do we have more targeted ways of blocking the IgA nephropathy pathophysiology? Again, with corticosteroids, it does look that overall we can reduce proteinuria and, at least in certain populations, slow progression of chronic kidney disease. But of course, there's all the corticosteroid side effects. So can we reduce corticosteroid risks while maintaining benefits? And at least early on, there's a suggestion that perhaps we can. As you know, you can target corticosteroids by using budesonide. Budesonide can impact the intestine and then have a huge first pass activity through the liver, so that the systemic exposure to corticosteroids are reduced. And you can further target it, as is done in the NEFIGAN study, by trying to get that budesonide to the mucosal surface of the intestine, the Peyer's patches in the distal ileum, where perhaps IgA activation and production is more significant. And what was shown in this study in phase 2, published in The Lancet 5 years ago, was that this idea seems to hold some strength, in that in a population as compared to placebo, different doses of targeted budesonide reduced proteinuria. And so you can see in the upper panel that the combined dose and 2 different doses reduced proteinuria by about 25 to 30%. And you can see the time line of that reduced proteinuria that was sustained through 1 year after 9 months of treatment in both doses. And in that study as well, there was stabilization of proteinuria, while the placebo group had about a 10% reduction in GFR. There was no reduction in GFR with this targeted corticosteroid therapy, the timeline shown below. And therefore, the delayed release budesonides being evaluated in a multi-center trial, the NEFIGARD trial. Enrollment's already complete, and the final study results should be available again next year. The study consists of Part A, which is a treatment phase, and Part B, which is an observation phase after the 9 months of initial treatment. And as you know, the FDA in the United States has already approved this drug based on positive analysis of 199 subjects who had completed Part A. And the initial data looked like this, where on the left-hand side was that phase 2 data showing the different doses of this targeted budesonide reducing proteinuria after 9 months of therapy. And in the phase 3 study on the right, there was similar reduction of proteinuria compared to placebo at 9 months. And again, very importantly, the preservation of GFR on the left-hand side seen in the phase 2 study was also recreated in the phase 3 study, where there was a 7% reduction in GFR in the placebo patients, standard of care patients, at 9 months, and no reduction in GFR in those patients on study drug. So again, very exciting early data with the opportunity to use this agent in the United States. But again, as we discussed, there's multiple opportunities to interact with the pathogenesis of IgA nephropathy in hoping to target systems that may help our patients. And on this cartoon, again, we can look very early at the mucosal surfaces and try to interrupt B cell or toll-like receptor activation. We can then go and try to get into the systemic circulation where immune complex is being activated, and perhaps again try to stop that from upregulating with B cell inhibitors there as well. We can get to the kidney and try to get to some of the root causes of that inflammation, such as by blocking complement with corticosteroids, with perhaps other cytokine blockers. So we have opportunities, and again, those opportunities are coming towards fruition. We again know in this 4-hit hypothesis that there's lines of evidence that has been reviewed and suggests that as you get to the kidney and the deposition of immune injury, that the complement systems are activated. Of course, we see C3 in the kidney, we see terminal complement activation in the kidney and the urine, and there's lines of evidence supporting activation of the lectin pathway and the alternate pathway. And when we look at opportunities to interact with that, there's multiple opportunities to do so. So there's already phase 3 studies blocking the lectin pathway and alternate pathway underway. And as you can see in the right-hand side, that multiple different targets are druggable, including C3, C5a receptor, factor B, the MAS pathway, factor B, the C5, factor D, and there are trials ongoing, both with oral agents, subcutaneous agents, intravenous agents, to try to interrupt complement activation. And again, preliminary data gives us hope that this may be a positive set of studies. Likewise, there's huge opportunity in blocking those cells that make galactose deficient IgA or the autoantibodies to them in an effort to more specifically target our patients with interventions that stop the pathophysiology of IgA nephropathy. And therefore, as this cartoon shows the progression of B cells from early bone marrow cells and germinal cells, from pro-B cells to immature cells to more mature cells that can go on and become memory B cells that can make antibody, or plasma cells making antibodies, that we have a number of approaches with anti-BAFF, anti-BLyS, anti-APRIL approaches, anti-B cell approaches with proteasome inhibitors, anti-interferon approaches that may prove to be beneficial. And several of these approaches are already in phase 2, and some with early phase 2 data suggesting, again, optimism that this can actually impact our patients. So taking this all together, it's an extremely exciting time in IgA nephropathy. There's numerous research priorities that need to be accomplished to still benefit our patient and still meet their ongoing need to get effective, safe care of their IgA nephropathy, to be diagnosed and not face a future requiring dialysis or transplantation. To get there, we have to successfully complete our phase 3 studies and look within those phase 2 studies and earlier programs for, again, hopeful programs that need further understanding, further study, and validation. We need to get to the point where we understand who is the right patient for the right medication at the right time. So we need to understand our patients better and be able to individualize their therapy. To do so, we really have to understand better the genetics of IgA nephropathy, how to interpret the pathology, what biomarkers and response to therapies will really tell our patients what their individual optimal treatment paradigm will be. Furthermore, if we're really lucky enough to have these growing combinations of options for our patients, maybe there are ways to combine these successful treatments to really improve their outcomes. And we need to learn how to prioritize both in the value world and efficacy world, which is the right way to start with these treatments. And hopefully to do so, we can develop a research international registry to look at our patients, what their characteristics are, and how they respond to therapy. So in summary, patients at risk of progression with IgA nephropathy must be identified in our communities, and the appropriate patients need to go on to treatment. Conservative therapy certainly helps, and we want to have maximal blood pressure control and maximal use of ACE inhibitors and angiotensin II receptor blockers to improve outcomes. SGLT2 inhibitors are very likely to be of additive benefit as we await the full results of the EMPA kidney study. You'll have to determine who should be treated and for what cost with SGLT2 inhibitors now. We also now believe that steroids are of benefit in reducing outcomes, particularly in some populations, but the adverse events remain quite concerning and they need to be discussed with our patients. But these newer general therapies that are coming along, such as endothelin receptor antagonists and others, newer anti-inflammatory therapies, such as targeted corticosteroids, anti-complement, anti-B cell therapies, and others need to be fully evaluated and hopefully, if successful, can be adopted. So thanks for your attention. Again, very exciting times, and I look forward to your comments and questions. Thanks again.
So we will have time for a question and answer, so please send your question and we will get started now. So the first question, Richard, congratulations, the lecture was beautiful indeed. You touched all the interesting points. There is a lot of things which can be further discussed. The first question from the audience is about budesonide. You say that this is available in the market, so you can confirm that. But the question is the amount of systemic absorption of this drug, and particularly the side effects which can follow the administration of this drug in comparison with standard corticosteroid therapy. And the other point is how to do with the withdrawal of this drug.
Thanks so much, Professor Coppo. Your introduction was so lovely. I really appreciate it. For that question, again, yes, the targeted budesonide is available in the United States to our patients under a provisional acceptance, awaiting definitive evidence of GFR preservation with the longer-term study. The drug is generally really well tolerated by our patients. And as described, the budesonide undergoes first pass, but there still is systemic exposure to corticosteroids, and some patients have mild, generally reversible side effects, such as you'll see with systemic corticosteroids, such as a slight Cushingoid appearance. There may be a little bit pressure on the sugars to go up, although the sugar tolerance was very good in the study, and development of diabetes was very rare and again reversible. So it is a well-tolerated medication. Systemic steroid side effects appear to be very mild and reversible, and we have to find again which patients are best treated with this and longer-term outcomes to see whether this approach can replace systemic corticosteroids.
Good. Thank you. The other point is about the use of renin-angiotensin system inhibitors. The question is for proteinuria, is better to use angiotensin inhibitors or renal angiotensin blockers, or the association? Which are the present conclusion?
Yeah, I think the important thing is not to differentiate so much between ACE and angiotensin II receptor blockers. We don't have a head-to-head study comparing efficacy, but at least side by side and general experience would suggest that they are the same. So you want to really utilize whichever medication the patient will tolerate, make sure they will be highly compliant with their medication, and really push the medicine to its highest possible dose, as long as the patient's blood pressure will tolerate it. The creatinine remains stable. They don't have high potassium. We know that utilizing ACE inhibitors and angiotensin II receptor blockers together can be dangerous, so we don't advocate that these days. But maximizing the RAS inhibitors and then looking for the opportunity to add other conservative therapy for patients whose proteinuria isn't more ideal is the way forward.
Good, thank you. Another question is about the use of SGLT2 inhibitors, if there is a glycosuria in non-diabetic patients under this drug.
Yes, you certainly are going to see glycosuria. It may not be as heavy as in diabetic patients, but it is routine to see 3+ sugar on routine urinalyses in patients who've been treated with SGLT2 inhibitors who have IgA nephropathy. Clearly, that leads them to have risk for infection, but the reported rates of infection in non-diabetic patients, based on DAPA-CKD at least, and in general experience, has been very rare and been very mild infection so far. So again, we can't use these medications with impunity. We have to watch and counsel our patients about risk for infection. But I think the risk is quite low, and hopefully we'll see in EMPA-KIDNEY that the benefits are quite substantial.
Good. The other question is for a particular patient. Would you consider corticosteroid in a patient with IgA nephropathy, proteinuria about 3 grams per day, normal GFR, but after splenectomy due to an accident?
Yeah, I think that's a great question. You know, the first part of it is to consider corticosteroids. I think when you have a severe risk factor, whether it's heavy proteinuria like that, and certainly more than 3 grams, would qualify even in a normal kidney function patient. If you have very adverse histopathologic findings, or if you have a rising creatinine, you need to be aggressive with your treatment. I still think that there's time to use conservative therapy, but if that does not lead to substantial control of proteinuria, considering immunosuppression is really important, and having a discussion with their patients is really important. Splenectomy, of course, increases the risk of encapsulated organisms and infections. So with corticosteroids, you want to be very careful. I would think in a well-vaccinated patient, though, against those encapsulated organisms with their pneumococcal and other vaccines, that it would be a reasonable consideration. Of course, my own bias would be to try to get that patient into a clinical study, still to get further determination about whether these emerging therapies are going to prove to be beneficial. But again, a educated discussion is well worth it, and consideration of steroids is reasonable.
Okay, thank you. Another point is dealing with hematuria, the role of hematuria, but particularly, which is your approach for a patient with hematuria, and would you treat persistent hematuria?
Yeah, that's a very important issue that we don't have clarity on as of yet. There's controversy in the field. I do believe that hematuria is an independent risk factor for a bad outcome in IgA nephropathy. I think episodic gross hematuria represents episodes of maybe a small number of crescents in patients, but we don't have guidance as to whether isolated hematuria in the absence of proteinuria, high blood pressure, or a falling creatinine is enough of a concern to be more aggressive with therapy. And I personally would not feel that it's a big enough risk issue to treat by itself. So that is if a patient has low-grade proteinuria, has a stable GFR, has well-controlled hypertension, the presence of hematuria bears follow-up and observation, but by itself should not lead to further increases in treatment.
Okay, good. Another question is about the dose of glucocorticosteroid. Indeed, the testing trial raised the issue about the optimal dose for the eligible patients. Which is your idea?
Yeah, this is a really wonderful question because over the last decades, we've seen numerous different ways of approaching corticosteroids in IgA nephropathy and indeed in many, many glomerular diseases. We are certainly learning that you can get more results with less and less corticosteroids. I personally, this is my opinion, like to use as little as possible. And so I certainly applaud the testing group for moving down in their doses. But we have to remember they used methylprednisolone. Their doses still represent prednisone doses of about 40 milligrams per day for 2 months for normal-sized individuals. And I would say that that's a reasonable dose. If you're going to go ahead with corticosteroids, you should remember to taper after 2 months like they did. I use even smaller doses if patients decide that it's worth the risk-benefit ratio, but those have not been well studied, so I'd caution you to stick where there's at least some evidence. But there's many different regimens. I think there's lots of different opinions, but you should monitor your patients for their tolerance, for side effects, and of course for early efficacy to see when you might be able to reduce their exposure.
Richard, do you think you can generalize the results of the testing trial to non-Asian population for these small doses?
It's hard to do because the patient was overwhelmingly first Chinese and then otherwise Asian. But I think if we look even at the studies that were utilized in other trials in European populations, particularly in Italy, and we look at doses where they used doses such as milligram per kilogram every other day, the doses do get to very similar to that, where they have been reported to have efficacy. So I think in terms of dosing, I would love to generalize that less is still going to be effective. It's sort of interesting to try to compare those regimens that use very high doses up front or use steroid pulses up front. But again, we just don't have head-to-head comparisons yet. Again, with the knowledge about risk and with benefit, I still in a camp. And again, it's just a bias and opinion that I like to minimize corticosteroids as much as possible if one chooses to use them at all, as opposed to using trials or newer medications.
Good. Very well, thank you. The other point is about, do you see any positive or targeting APRIL or BLyS together versus just APRIL alone? Obviously, upstream targets to stop the production of autoimmune complex formation would be the best therapy, theoretically.
Yeah, that's a fabulous question. For the first part, again, how to best suppress inflammation by B-cell control, how to best suppress IgA production, particularly galactose-deficient IgA. It's hard to know whether a single cytokine blocking B-cell development versus multiple cytokine approach is going to be more effective. That's why they're doing trials, and I'll just stand by to say that we need to wait for results to really know. Blocking multiple cytokines could potentially be more efficacious, but might also bring in more side effects. So we'll wait to see. In terms of targeting the pathophysiology upstream versus downstream, again, it's a great question. I think we have to wait and see which will be more effective. We also have to think in our more severe patients whether we'll ultimately adapt a process of doing both or doing them at different times, where you'll want to get your IgA, especially your pathogenic IgA and immune complexes, well controlled, but you also want to protect the kidney with local anti-inflammatory approaches, such as targeted steroids if they prove to be highly safe and effective, or blocking those things that mediate inflammation, such as complement or other cytokines. So great question, but I think we have to wait and still learn more about that.
Okay, thank you. Very well. The other point is you showed the results of the testing trial about proteinuria with the beneficial effects lasting for some years, but ending at least after three years. So the point is how to manage patients already treated with corticosteroid, for instance, the Manno protocol, with good response that after some years show proteinuria gain.
Yeah, and I think that's something where, again, even though there's so many treatment protocols for IgA nephropathy, how to treat patients with anti-inflammatory therapy or immunosuppressive therapy beyond the first 6 months is really pretty much unknown and unestablished. And I think for patients who are treated up front and then relapse or have residual significant proteinuria, again, my own opinion would be that prolonged immunosuppression with corticosteroids at low doses or alternate day doses may be a little bit dangerous, that we need to know more about steroid-sparing therapies, such as maintenance with Imuran or with Cellcept, which is interesting, but for right now, I'd say completely unproven. And then coming in later after initial immunosuppression, I think conservative therapies, hemodynamic therapies will be quite warranted, but in terms of a secondary form of immunosuppression, we're going to need to learn how to use those effectively over time and to judge again the safety in our patients, and there's still lots of studies to be done.
Very well. Again, on the point of non-immunosuppressive therapy, there is a question. In a patient who is intolerant to ACE inhibitors or renin-angiotensin blockers, so they are contraindicated, which is your choice for the other options you presented? Other
so I think blood pressure control is still really, really important. And I would try to learn lessons that maybe staying away from vasodilators that increase glomerular pressure might be good. So I would tend to stay away from vasodilating medications like the vasodilating calcium channel blockers as monotherapy may actually be bad for the kidney and bad for proteinuria, while beta blockers and non-vasodilating calcium channel blockers may be better choices. And then moving to therapies like SGLT2 inhibitors, endothelin antagonists may prove to be highly effective. The best diet and exercise would be a good thing to do. So again, there are other ways to benefit our patients beyond RAS inhibitors. And for those few patients who are sensitive to those, including direct renin inhibitors, we'll have to keep looking for our best support.
Good. We have other questions. So this is very of interest. So the point is, do you perform renal biopsy to assess interstitial damage and crescents in a case of a patient with rise of creatinine so rapid that GFR is below 30?
Yeah, it's a great question. And I think we need to know more about what is the point of no return, where further aggressive and expensive therapy is unlikely to help and more likely to hurt the patient. Again, I often will use the GFR value alone to decide that. And I think less than 30 is where you certainly get anxious that you're at that point. A biopsy can be utilized to look to see whether there's still largely inflammation or more fibrosis to guide that decision, but we don't have a hard measure to determine that. And so again, it has to be individualized for our patients. And I could go on further, but I do think we've run out of our time for this session and really appreciate the great questions and interactions from our audience. So back to you, Professor Coppo, to close us out.
Okay, that's a pity because we had other questions, but this underline the interest of this discussion. It is time to wrap up. It is a very instructive lecture, and the discussion was so brilliant that I think it was extremely of interest for all of us. So thank you for joining us, and thank you, Professor Lafayette, for this beautiful lecture.
Great
Thank
pleasure.
you all.
Thank you.
Bye.